we'll move on to Katie Riordan, who comes to us from University of Arizona College of Medicine in Tucson. She is going to be presenting today on a DBS case for Parkinson's disease. She's done research in across multiple different areas and has published a number of peer-reviewed publications. Katie, we're looking forward to your talk today.
All right, can everyone see my screen?
Okay. Looks good.
Awesome. So hi everyone, I'm Katie Riordan, and today I will be talking to you about a DBS case that I saw performed by Dr. Capel and Dr. Park. So getting into the background of the case, the patient is a 66-year-old male with advanced Parkinson's disease who's presenting as a referral for surgical intervention. He was first diagnosed in 2016, and his main symptom burden arises from motor fluctuations and drug-induced dyskinesias. So he's been having a lot of problems with body slowness and gait freezing. In his off state, which was his off medication state evaluated when he was seen by a neurologist prior to this consultation, the Unified Parkinson's Disease Rating Scale, which is an objective way of quantifying symptom burden for these patients, looking at his motor exam, his score was 59 on a scale of 0 to 108. And then following medication administration in the office, it improved to 29, so about 50% improvement. And prior to him arriving to the neurosurgical clinic for evaluation, he was seen by neuropsychiatric providers who determined that he has low risk for cognitive decline following surgery. On exam in the office, he was awake and alert and oriented. He's has an otherwise non-focal neurologic exam. And the biggest things that were noticed were that he has moderate dyskinesias of his bilateral arms and legs and heads with rigidity in the bilateral upper and lower extremities. This is consistent with the findings that were seen in his neurology office visit, in which he was experiencing severe bradykinesia and gait freezing. So given this, we want to talk a little bit about the indications for DBS, and there are three main points. There's patients experiencing motor fluctuations, patients with levodopa-induced dyskinesias, and patients with medically refractory tremor. So given that our patient is a patient with advanced Parkinson's who is experiencing motor fluctuations and having severe bothersome bradykinesia and gait disturbances secondary to wearing off of his medication, despite trials of multiple classes, he is considered a good candidate for DBS. So the plan was to proceed with bilateral GPI DBS with an anticipation for improvement in his motor fluctuation and dyskinesias, which could allow him to have further up titration of his medications to aid with his gait freezing. So a big part of DBS is the accuracy of the microelectrode placement. And one of the targets that we use for this is the subthalamic nucleus. And with traditional MRI sequencing, such as the T1, it's difficult to see the subthalamic nucleus, which is a small part of the brain with an oblique orientation and multiple variations in its anatomic location. So when we're looking at the MRI, it's not totally obvious where this may be. So one of the ways to overcome this that Dr. Capel was actually involved Oh no. Is it back? Okay. Sorry about that. I was told that my video froze. So the quantitative susceptibility mapping is part of the planning that Dr. Capel was involved in, which is what we're seeing here. This is an MRI sequence that is based off of the iron distribution in the surrounding tissue, and it's a promising technique for imaging of the subthalamic nucleus and surrounding gray matter tracts and white matter tracts to help us better localize the targets that are involved in the DBS planning. So when we're looking at these images, we're getting a better idea of where the GPI is in relation to the surrounding brain tissue, offering higher resolution and more accurate targeting. So when we're doing our planning, this is one of the images that gives us a better idea of where the subthalamic nucleus is located in regards to the surrounding brain tissue as well as the GPI. And this will help us give us better planning for the actual DBS. So in the OR, there are a few different ways to do this, but Dr. Capel uses a Lexel Vantage frame, which is a modified version of the traditional Lexel frame, which is a smaller non-metallic reinforced composite material that limits the MRI and CT artifacts to help with preoperative imaging. It also lacks some of the crossbar framing that is seen on the traditional Lexel frame to allow better visualization of the patient's face. Are you serious? Is it still frozen?
No.
Is it? Okay.
No, it's good.
Okay, sorry. I have people in the room who are helping me. So we're seeing here the Lexel frame with the actual apparatus attached to it on top. So within the OR, the Medtronic Stealth Station is the navigational software that's used for these cases to allow anatomic reference throughout the case. So this is some of the imaging software that's used on the left side, and then the O-arm is the intraoperative CT that is used. And getting into what the intraoperative planning looks like. Just as a disclaimer, these are images that were taken from a DBS planning case online. These are not the images that were used for our case specifically. But within DBS, the anatomic landmarks that are used are the anterior commissure and the posterior commissure, which are not totally visualized on this, but we can see part of the anterior commissure in these images. And the reason that these are used is because they have reliably consistent relationships to other structures within the brain and connect as coordinate spaces, with the center being the mid-commissural point, acting as the point 000 that we can then base our location and targeting for the GPI and other basal ganglia structures in DBS. So based off of studies that were done in cadavers in the 1960s, we used the coordinates of 21 millimeters lateral, 2 millimeters forward, and 4 millimeters deep to this mid-commissural point to locate the GPI. In our case, the targets were adjusted intraoperatively after obtaining a CT and were overlaid with the MRI that we had originally. And we came up with the target points of X is 79.3, Y is 102, and Z being 97.3. These are spatial orientation coordinates where X is in the left-right axis, Y is the anterior posterior, and Z is depth. Getting into what this actually looks like, this is where the frame is placed onto the patient. And we have the apparatus and targeting device attached to the patient. So a incision is made, the targeting apparatus is applied, and then a burr hole is made in which the cannula can be inserted. And once we are at the target depth, a microelectrode is inserted into the burr hole. This is the macroelectrode, but a microelectrode is placed first, and the microelectrodes help us find the exact targeting location that we're looking for. And so the microelectrode is placed first, and to help us to locate the physiologic characteristics of the GPI, including firing rate and patterns of its surrounding neurons and structures. Once the microelectrode is placed, we get another intraoperative CT to confirm that it is close to the target that we were looking for. So here were the intraoperative CTs that we found. Of note, this is the patient's second stage. So the left was something that was placed previously by Dr. Capel, and the right side is what we were looking at for this operation specifically. So this was an axial view, and here's a coronal view of what we were looking at intraoperatively. And finally, here's the sagittal again. Here's the left side that we have already placed previously, and the right side looking to be near the targeted location. But going back to the microelectrodes, part of the physiologic characteristics of the GPI is that it's different from surrounding cells. So this is part of the microelectrode microelectrode recordings that we see intraoperatively to confirm the placement. And this is completely different to what we may be hearing or seeing in the surrounding targeting sites, such as the subthalamic nucleus or the GPE. So once that is placed, we do insert the DBS electrode, which is a little bit larger than the microelectrode, and then we confirm placement with an intraoperative CT. So or intraoperative X-ray, excuse me. And once we have our electrode placed, we're hoping for it to be within this target in this box, which is what we're seeing in the image. And then this was also a CT that we had performed. So there are multiple checkpoints to ensure that we're in the right place. But prior to completely finishing the surgery, macro stimulation is also used to determine the voltage thresholds for clinical benefits that the patient can tolerate. And also impedance values are checked, which is routinely done during the surgery to identify any electrical conduction deficits that may be occurring within the system. And our patient was able to tolerate up to 4 volts, which is what is used routinely for clinical benefit in patients with DBS. And here's the postoperative X-ray that was obtained after the surgery was done. So for a postoperative course, the patient was discharged home on postoperative day 1 without any complications. He tolerated the procedure well. He returned 7 days later to have his IPG placed, which is the battery to allow the apparatus to work and be used. And then he was most recently seen in the clinic on postoperative day 13 following DBS placement for the suture removal. At this time, he wasn't having any complaints. He had been doing well. His incision looked good, and his sutures were removed. And he will be returning later this week, actually, for a more formative postoperative evaluation. And then I just wanted to say I am interested in looking at which patients have received DBS in the past, and this is currently a manuscript that I'm working on and preparing to publish with my mentors back in Arizona, where we had done a literature review looking at which patients had received DBS and if there's any relationship to men and women who may be receiving it. And so far, some of our data is showing that men, although they are more likely to be diagnosed with Parkinson's, they are part of the majority that do end up receiving DBS. And there's a lot of variability in the ethnic breakdown of patients who end up receiving this too, which is just something that I find interesting. And that's it for me today. I just want to say thank you so much for having me this month. And if you have any questions, I'm happy to answer them.
Good job, Katie.
Thanks, Dr. Patel.
Katie, do you have any comments on how Dr. Coppell or others might choose their target for DBS for Parkinson's disease?
Yes, so the primary targets are the GPI, globus pallidus internus, and the subthalamic nucleus. The subthalamic nucleus is more commonly used for like tremor control, whereas GPI can be used for dystonia or for the medication-induced dyskinesias. So it's looking at the patient and seeing what symptom burden that they have and which ones would be more appropriate for them.
That's sort of in the realm of right, Katie. It's a little not completely accurate. I mean, if you look at the statistical data in the literature, there's really no difference between the phenomenology treated by STN versus GPI. Nonetheless, more experienced centers do have in their own minds a protocol about choosing GPI versus STN. For my sort of thought process, in general, if a patient has one of two scenarios, GPI makes it easier for the neurologist to manage the patient. One of them is if they have very, very low dose induced dyskinesias. And so with GPI, which has a more direct dyskinetic effect, where STN requires a reduction in medication, you can maintain certain dopaminergic stimulation for the patient, because, you know, ultimately patients are not making enough dopamine. So you do have to replete them on some degree. And so therefore, in that scenario, GPI may be a better situation. Also, if a patient has gait that is improved with drugs, dopamine, again, those patients tend to do better with GPI in the long run, because you can maintain higher dosages of dopaminergic repletion and still control some of the other side effects of that medication. So that's kind of the main difference. You know, they both are really good for tremor. You can make an argument that if somebody has an PD variant, essential tremor PD variant, that the STN location is better, because you can sort of finesse it and pick up another track called the DRTT, which is essentially the cerebellar outflow into the thalamus at that STN location. You kind of get 2 for 1 there, but that's kind of a subtle point.
Okay. Thank you for clarifying, Dr. Capel.
Katie, your answer still would have passed the oral board's general section, maybe not the functional section.
Okay.
Do you have any other questions before we move on?